oversight and the allocation of resources in our system. So one of the things I've been working on over the last few months is our strategy process, and we're trying to do something different with our strategy. And I think the plan, Janet, is that I spend a sort of 5-10 minutes giving a quick run through what we're aiming for. It's a process where I'm really pleased that the VCSE and Christopher and others have been really actively involved. So we've had huge engagement from VCSE partners in our online events, in our 100 Leaders event at the end of July. And of course, the VCSE will be represented on our Integrated Care Partnership, which is a senior group of leaders from across our system that's formally responsible for the strategy. So, and I should add that on a personal level, I'm keeping on injecting a VCSE element to all of the different potential options that we're considering on the strategy, because you know, on so many of these really big problems that we're facing, the VCSE is the source of creative thinking and innovation, and challenge to the NHS simply repeating what it's tried for many decades on things like prevention or, you know, children and young people's mental health. Anyway, here am I waffling on. Let me show you a few slides, and then I'm really happy to answer questions as best I can on what we're up to. So let me find my slides. There we go. So can you see that? Yes. Super. Yep. So the first thing is, we spent a long time in the spring and the early summer thinking about what we're trying to achieve with an integrated care strategy for the whole of our system. And I can speak frankly to you, because I won't annoy you as much as my NHS colleagues. But one thing I did was I looked back at our existing strategies, and often through no fault of our own, but because of the obligations that we have to the national NHS, I looked at those strategies and thought they really were problematic. So our last big strategy was implementing the NHS 5-year forward view, and we had a 300-page strategy with thousands of different objectives. And once you've got 300 pages and thousands of different commitments, it's very hard to ensure the resourcing and the focus or the monitoring of progress needed to deliver any of them. So I think where we are is that we want to do something different this time round to what the NHS has traditionally seen as good strategy. So we're not trying to create this umbrella telephone directory document that claims to map out everything that's happening in our huge and complex system, and claim that we have some master plan to orchestrate everything that our 100,000 plus staff do. Is just not helpful or practical or effective. So instead, what we want to do is we want to build a vision, provide everybody with, some high level guidance about the sort of health and care system collectively we want to build, and then we want to focus in on a really small number of big opportunities for cross system change. We're looking at areas where we think there's a pressing need to improve patient care, and where we think that cross-system working at the level of South East London could make a really big difference. So we're focusing in really tightly, and we're not trying to duplicate all of the different important things that will need to happen in our system, which are already in somebody else's strategy somewhere. And we will see whether we can stick to that, because it's a very different way of working. The process, we started with a big conversation on opportunities and challenges for our system in July and August, including, as I said, lots of VCSE participation and also engagement with our communities online. We're now in the process of trying to home in on those 3, 4, 5 big areas for our big strategic priorities to home in on, to focus on. We're also developing our vision, and I can share where we've got to you on that later, and welcome your thoughts. And then in the autumn, another sort of really fundamental problem when we looked at existing NHS strategies is they tend to be sort of long lists of ambitions to fix things, to fix, hugely difficult things like, we're going to shift to prevention, we're going to ensure high, easy access to high quality, this, that, and the other. Our strategies tend to be ambitions rather than thinking through how we would deliver any of these things. So one thing what I've been sort of pushing really hard is that the strategy must have an element of, well, how are we going to do this? If we say this time round, we're really serious about the switch to prevention and a focus on well-being, well, we need a kernel of a strategic approach to that. And that will be the work of the autumn when we've clarified exactly where we're focusing in on. We need to decide, well, what have we tried in the past in different areas? Has it worked or not? What are other health and care systems in the UK and internationally doing? What's the evidence? And what's the overarching strategic approach or model that we're going to pursue? On the vision, very quickly, again, vision statements in the NHS tend to be sort of grand statements of how everything's going to be brilliant in 5 or 10 years when we're all in different jobs and no one will hold us to account for it. I think a vision really needs to give concrete guidance. We've got 100,000 staff and they will go out and do their jobs day to day and improve services, broadly sort of irrespective of what we're doing at the centre of our integrated care board. So what we're aiming for is some guidance and some permission. Go out and change things, go out and improve, but do it with the following broad principles in mind, and try to avoid doing the following things that we know have not worked in the past, is what I think our vision should aim for. Here are two good visions. I won't dwell on those in any great detail. Our vision, I won't read it out, but we're focusing on health and well-being, convenient care, whole person care. So it's very interesting that we've talked so much in the NHS about holistic whole person care, and yet in our second sentence we then typically go on and talk about a new specialist services for cardiovascular disease, or homing in on our diabetes pathway. So we talk about whole person care, but then we talk about individual diseases and structure our services around individual diseases. So there's a real challenge for us to make good on this commitment. We've typically delivered general services for the whole of the population, and I think we want to make a commitment to tailoring our services to women, minorities, deprived groups, because we know that general models of care that might work well for most of the population do not necessarily deliver for particular groups within our population. So primary care is a good example. The sort of primary care that we've got works quite well for the middle classes, but we know that quite different models of primary care are more effective for really deprived groups. We want to focus on partnership with our service users. So, as I mentioned, I think, there are two real sources of inspiration for the traditional NHS. One is the VSSN and the other is the public, in terms of challenging us to see our work in a different way, and we want to empower our staff. Now, just to skip through, we are thinking about 4 or 5 priorities that will, where working together across our system could deliver a really big impact, and where we can build our capability in leading transformation. We're looking for really big opportunities. We're looking for opportunities where there's a compelling case for system working, and we're looking for things where we think practically we could deliver some impact over the next 3 to 5 years. Again, I won't skim through this. This was what we talked through with our board yesterday. We're looking at 4 areas. So we've got health and well-being, so prevention and well-being, children and young people, adult mental health, and primary care and long-term conditions and complex needs. And we've got three or four potential priorities we're considering in each area. So for health and for prevention and well-being, you know, we could consider homing in on, you know, sort of doing proven primary and secondary prevention, things like, you know, screenings and health checks and vaccinations as effectively as possible. We could focus on, you know, supporting people to live healthier lives, or we could focus on the broader social factors that are influencing whether or not people can live healthy lives. We're looking at, for children, we're looking in particular, I think this top potential priority is hugely interesting. So, you know, we know that you know, our accident and emergencies right now are full of white teenage girls, sort of 14 to 17, with sort of you know, with anxiety, depression, and eating disorders that have not been sort of picked up and addressed earlier. So if we could do something with the VCSE in particular to break this cycle of having overwhelming demand, rationing access to services, letting children's conditions worsen, and then finding our specialist services overwhelmed, that would be hugely exciting. On adult mental health, similarly, I think probably the best the most interesting candidate at the moment is this third option. So how can we be better at early intervention for adults in crisis? Because we know that there are really powerful VCSE-led, peer-led models that can take the pressure off traditional services and maybe be more effective than traditional services. And then for primary care and long-term conditions and people with complex needs, well, this is really tricky because all of the four areas that we're considering here are really compelling. But if it were me, I would probably home in on how we work across the primary care system and the hospital system to join up and deliver more proactive care for people with long-term conditions. I know with my parents, I see them sort of bouncing from one health service to the next for different long-term conditions. They're constantly, you know, traveling in their 80s to different services, and we know that we could join this all up in the community. And the other area I'm really interested on, this final one before I shut up, is, you know, we have people with a higher degree of complex needs. So we've got, you know, the most frail older people with more severe problems, with, you know, physical health problems plus dementia, plus, you know, problems of social problems. We've got you know, struggling families, people with severe mental health problems who also have typically often, you know, physical health and social challenges. And we know that these people are having getting terrible outcomes from our system at the moment because we're not providing proactive care. They don't have care plans often, or good care plans. And these people are bouncing into hospital A&E, hospital wards, residential care, police cells. And again, there's a lot we could do to develop a better model of care for them. So I'm going to stop there. I think that probably gives you a good enough overview of where we are. Really welcome your reactions.
Right, does anyone, I'll start by asking one question. This is for the Southeast London. Do you know whether it's in any way comparable with what is happening in other sectors in London or around the country?
Okay,
or
Janet.
Are you all working alone?
I will take that one, and I will think about it. Can I take a few and I will note them down?
Right, Laura.
Mine was just a comment to say it's very refreshing, your approach, because you're being very real about how strategies have and haven't worked in the past, and it seems that you're taking a very kind of real and results focused approach to it, so it's very welcome.
Good.
David W.
Thanks. I'd like to echo what Laura just said. You know, it's great to be engaged in this. And it's good to do that. And I was at the VSSN event in the Oval back at the end of July. So I've seen that from there. I think I've just got two main comments on the actual content of this, which is one that I know that was raised at that meeting in July, which was when it came to mental health. There was definitely comments about the join between adolescent and adult mental health, given the level of which, these sort of issues present primarily in adolescents. And I think that there's a worry I have, which was articulated in the room, about siloing adult mental health. That hasn't changed, and that was quite a significant thing that was said. And so it still appears to be siloed in this, and I think that's a real missed opportunity, genuinely. My bigger part from a Bromley Well perspective as well is another area that I know was raised significantly at that meeting was the issue of carers. Here in Bromley, 1 in 11 people, 31,000 residents, is a carer. We have the highest number of over 60, of over 70s for any borough in London. We have over 58,000 people who are over 65 and carers, and we also have literally thousands of adult carers, mental health carers, mutual carers, lots of them. The word carer is not mentioned once in any of this. It is absolutely crucial to a large number of people getting the support they need to do that. It's crucial to helping and support people with mental health. It's crucial in terms of supporting discharge from hospital, hospital from home, a range of other priorities that we have. So I would very much like to see something around carers. I should say I'm closely engaged with the Carers Trust nationally. I met with their Executive Director of Policy only on Tuesday. There's some very good practice happening from Blackpool, where there's a carers charter, to Norfolk and Waveney, which is a similar elderly population to Bromley, where they're having basically a tick type of an approval type approach, but significant engagement. And there is a statutory duty now under Section 25 to engage carers in this. So I would expect that to be included. As a part of statutory duty, I'd expect to see something about how carers are engaged with in this strategy, and it's not currently there.
Samantha.
Hi, hi Ben. Just a couple of things that I noted. I just wonder whether you have any involvement or have been in discussion with anyone on the 0 to 25 SEND transition board. They're currently working on a strategic plan that kind of aligns quite usefully with what you've just put up. So I wonder whether there's a conversation to be had there, because there may be some duplication. I mean, I know they're really working on that whole kind of transition, and it's a really big project that's happening at the moment. So I don't know if you're involved in that, but I think that would be quite useful for you. And also, I wonder if also you're included in the proactive Bromley strategy, or at least speak to someone within Bromley of the strategic, because they are currently also designing the next 5-year plan around sports health and to improve sports health and well-being in Bromley. So just two really big strategies that are happening really that could align quite nicely with what you're doing. So just really a point of that, and thanks for sharing that with us. I mentioned in the notes that I'd quite like to perhaps meet with you outside of this, because we are working quite a lot of areas with a lot of partners around a massive number of points that you raise. But rather than bore everyone on this meeting, I think maybe we can give you some further information around what the sector's doing for children and families. Thanks, Ben.
Thanks, Sam. So David J and then Tony, and then maybe we'll let Ben answer his string of questions.
First of all, Sam, you never bore us. You've always got interesting points that I agree with. So I think as someone who suffers with type 2 diabetes, but I've got none of the other complications, it's really good that you're beginning to look at the treatment of long-term conditions holistically. Yeah. So that because my dad and stepmom have to go to 15 different hospital appointments, it seems at times, and it would be good if they could if we could cut down on that. I think the work you're doing on it's a really good strategy, and it's good that you're engaging with us. I think your priorities are on the different headings are probably right. I think there is a big crisis in CAMS. I think in terms of carers, it's how do you support them? How do they share good practice, what they've learned? So I remember when I worked at another university, one of the academics wanted to set up a sort of mum's net for carers. So the idea was that carers could share their experiences, and also I think with carers you have to recognise that I don't know if David knows how many, but I should imagine there are a lot of child carers out there, child and teenage carers, and they have special needs for support and things. And I think because they are digitally engaged, they're probably a good group to work with digitally. And that's really all I have to say, but it's a really good first step, and I'm very impressed.
Thank you. So Tony H, and then back to Chris. Ben, I should say.
Hi Ben. Thanks very much for sharing all that. And it does, I echo what other people have said. It does sound very good. And I don't want to sort of throw a spanner in the works, and I don't. Please don't think this is the case. But there was a study in the International Journal of Integrated Care recently, and if I may, there's just a little bit I'd just like to just quote from it, and I'd be very interested in your comments on it. The study said that of the pilots and things that have been undertaken, it said there was little stable or shared understanding of what integrated care meant, resulting in different practices and priorities, and increasing focus on reducing unplanned hospital use among national sponsors created a mismatch in expectations between local and national actors. Pilots in all 3 national programmes made some headway against their objectives, but were limited in their impact on unplanned hospital admissions. So there's, and I think I mean, I think that, I don't know, integrated care, I think I remember it being bandied about in the early 2000s, mid 2000s. It seems to have gone on forever and never really got off the ground, and it does seem as though a lot of that is around people. I think somebody else mentioned almost working in silos. You know, this is our bit, we're social services, this is your health, and the integration has always sounded to me like the perfect solution that actually never comes to fruition. And
okay, Ben, over, off you go.
I think we need an hour for Tony's last question. That's usually interesting, Tony. Let me race through. I've got another meeting at 11:30, so I've got 3 minutes to answer all of this. Janet, similar to other parts of the country, I know a little bit about what's happening in other parts of London. I've talked to some consultancies working on different strategies. There's a kind of a little bit of me, and this might sound terribly arrogant, that just thinks that there is little best practice in the NHS, the public sector in general, and in the national government on good strategy, and that we must be brave and we must do a strategy that we think really works for us and reflects best practice more broadly, because the national NHS would be very happy with another strategy like the last ones with 300 pages telling us we're going to solve everything, but we know that that's not how Steve Jobs does strategy, or we know that that's not what best practice looks like in other sectors. So I'm trying to stick to our guns and do a strategy that really is going to deliver something, even if other parts of London or other parts of England do differently. We will see. It's not it's a tricky balancing act.
And as much as anything, I was thinking about working silos. It would, if every sector produces its own strategy and they're all a bit different, are we any better than we were before? But don't answer that.
I will think about it though. David, fair point on mental health, adults and children. There might be an opportunity. You prompted me to think about whether or not we might. We're heading towards looking at sort of early intervention for both adults and children. Maybe we can bring that together and address the problems that we know are very real in terms of transitions through that. I'm just conscious though on a lot of these things, like for example, there are going to be so many important things that we're not going to fix in this strategy, and the challenge is to pick a few things and do them really well and build our transformation capability as a system through being focused right now, because when I compare our systems to international health systems, we're really weak on transformation capability, the ability to lead large-scale change, and we're only going to get there if we're quite narrow. But it's a good point I'm thinking about. The points on carers, it's entirely down to me. We should be referencing carers in quite a few of these priorities. I'm foolish, I'm a carer myself, and it's exhausting. So I'm definitely going to fix that, but thank you. It's a very good point. Samantha, I'm going to go and talk to Bromley about their strategy and our strategy in a couple of weeks' time. So hopefully, thank you.
And
thank you
also,
for that
sorry,
point.
Ben, just really quickly might be useful is to contact Rachel Dunley. I know that I don't know if you've already done that, but again, around their strategy around early intervention. So might just save you a bit of work, that's all.
Super, and let's follow up to talk separately as you suggested in the chat. That would be really helpful. And yeah, David J, likewise, I'm just astonishingly frustrated by, and this is because I'm astonishingly frustrated by how we continue to parcel up individual long-term conditions. It's crazy. And the doctors do it, and the medtech people do it, and the commissioners do it. And it will be a really interesting challenge to stop that. And the VCSE perspective and the patient perspective and the carer perspective is what we need to bring into those conversations to prevent the same professional views of the world dominating. And Tony, very lastly, before I go, it's really interesting. Integrated care is not a useful concept to me. It's just a piece of jargon like population health, and people just get lost in it. So I try not to use it. What I think we're really interested in here is building joined up multidisciplinary team-based care wrapped around the individuals close to their homes in the community. That's the thing, that the first form of integration that I think is concrete and matters. We don't want care from our GP and a hospital specialist for this and another specialist for that and a community nurse for something else and a social worker for a different thing. We want a team of people who hold our care in the community close to us, who work together, who share information, who don't duplicate their work. That's the first cornerstone of something that's meaningful about integration. And the second is joining that up with the hospital so that stuff happens close to home in the community wherever possible, and the hospital expertise comes to the community rather than we sending our 80-year-olds off to specialist outpatient services. But it's a very fair point. Then on the evidence, does any of this stuff work? As soon as you start looking at large numbers of pilots and experiments, the evidence is underwhelming. These are really difficult changes, and if you look at 50 different integrated care pilots at any particular time, 45% of them are disappointing. I view it in a different way. I say, we know that there are places around the world that have developed really good team-based primary and community care, and they have done it and they have proven that it can work. So we need to take their magic and apply it in our system and work really hard to get the same results that they got. But that's a huge quality improvement, innovation and implementation challenge.
Ben, can I just ask, why do you think it's taken so long though for this, because there have been good models around, but why has this never moved forward? Is this been going on for years and years?
So here's an example. Before I got to go, I did a study in my old job of the Alaskan team-based model of primary community care for the native Alaskan community, and then and it's brilliant. And then they came over here and they looked at some of our attempts to replicate that model, to do something similar, and they said, what you've done is nothing like what we did. We have teams of doctors, nurses, mental health professionals, technicians, healthcare assistants, and they sit together in an open plan office together, constantly exchanging information. That's teamwork. And what you've done is you've called a group of people, a multidisciplinary team, and they join a conference call for 30 minutes on a Monday morning. Yeah. There's a huge gap between what they did and what we've done. And it would be, we just need to be much, much more committed, both in the level of the change and reorganisation that we need, and the measurement and the continuous improvement that you need to achieve the benefits that they gained. So so I remain hopeful despite all of these negative articles is the bottom line. I'm really sorry I've got to go. I'm late for another meeting, but lovely to talk to everyone.
Ben, thank you very much for
you
coming
very much.
along.
Thank you very much indeed.
And sorry
Yeah.
to detain you. We will share some of the comments and feedback. So thank you.
Thank you. Bye.
Right. So shall we go back now to the Ukraine? I mean, we've got half an hour. So is everyone okay for us till about 12-ish?
Just
Sorry, can I just ask, will those slides that he shared be circulated?
we will make sure that the slides are circulated. And the other thing is, obviously, there's been various bits of commentary and requests and asks for Ben in the chat. We'll make sure that's all circulated to Ben, so he's got the opportunity to reflect. I've been on a number of meetings with Ben. He's obviously very cerebral. It was interesting hearing him talking about the Alaskan model. I know you've got to go, David, so thank you. That was absolutely fascinating because they actually had somebody attending and participating from Alaska on one of their recent events. They didn't come over from Alaska. They obviously joined like we are. And that model has been in evolution for 10, 20 years. It's not something that they've just sort of rolled out. And one of the things they talked about was around not just teams meeting together and sharing space, but actually those teams going into the community and actually sitting in community spaces and community forums. So they weren't just going to consult, they were going to sort of co-share that space, really. And it was that, and I think they talked to, one of the issues they talked about was mental health and some of the mental health challenges there, and the fact that when they put services out there, nobody was actually going and utilising the services. And one of the things that one of the consequences of that was that rather than asking people to go into the services, they went out into the community and actually essentially embedded themselves in the community and coexisted. And that actually developed relationships with people within the community. And as a consequence of that, people began to develop relationships of trust, and consequently they began to use services. So it clearly wasn't a quick win, but it was an interesting model, and it's interesting the way they think about that. Just in terms of they've done a series of consultation exercises. One of the ones that Ben mentioned was at the Oval Cricket Ground recently. Ben Taylor from Mind went along. David went along. There were a number of other people locally. There clearly is an openness and a willingness to listen from some of the strategic players, but on the other hand, there's equally a danger of siloing some patients into different health categories and cohorts. So the other thing that I think we should be mindful of is that actually the strategy itself and the objectives are actually quite broad, and they're broader than health and social care. So the conversation that they're thinking about is addressing health inequalities, but they're also thinking about the social factors that influence health. And I'm just sort of mindful that we do need to sort of not forget the social and economic drivers, and the role sport can play, and the role physical and activity can play in all this, and how to align it. So it's not just about health, it's not just about hospital care, it's about the system really. And that's why Sam's comments about the sport and physical strategy that's evolving and moving at the moment is important. So I don't know whether anybody else has any other thoughts, and something we should just retain and just note and feed back to Ben before we move off this.
David J, do you want to say anything?
I'll unmute.
Yeah.
Okay, so I think that on the healthy inequalities issue, we're good partners to work with them. So I'm chair of trustees of another charity that isn't in the borough. It's in Haringey, and they the local NHS trust recently gave us a grant to work with them on outreach to the Eastern European community for women's health screening. So we now have 3 part-time workers who, as you said, Christopher, are you Christopher or Chris?
Christopher.
Okay, Christopher. As you said, it's important to build a trust with those hard to reach communities so they will use the service. You can't simply say the service is here. So I think we do have a role in that. The other thing in terms of integrated health, though, at its very early stages, is a lot of people now wear these watches and they have sensors on them. And are there ways of using the sensor data you're getting back to help monitor health conditions better? So, but that's because I'm a geeky person and I'm interested in that sort of question.
Okay.
So
right.
Thank you for letting me
you.
speak.
Okay, that's a good point anyway to add. Laura.
Sorry, I'm off. My mic is already off. On. I thought he was very impressive, but I did question whether the kind of boldness of his approach in verbally matched the document that he showed us, because actually the document that he showed us looked to me like a very familiar kind of strategic document. So I would really like to see those slides just to kind of read it more fully, because obviously we didn't get a chance to do that. The other thing that occurred to me is obviously at the moment this isn't a developed strategy. This is about looking at key strategic areas. So we are at very vague points, so some of that detail is not going to be in there. But it was interesting when people did raise sort of specific areas like transition from children's to adult care and also carers focus, that he did mention that obviously they need to have quite narrow strategic priorities in order to achieve results. But what I'd like to see is recognition within the strategy that there are some other strategic areas that will be looked at a later time, if you see what I mean. So I guess there's a sense that we've got to make sure that even if they're focusing on certain strategic areas, the other priority areas are still somewhere, are recorded somewhere or captured somewhere, so that they're not lost. So I really would like to look at those documents in more detail, really, is what I'm saying.
Yeah.
Sorry, I just reminded
No,
them.
I think that's a good